Good evening, everyone. A warm welcome to all of you once again for the International Lecture Series on Clinical Nutrition, organized by Clinical Nutrition Excellence Academy, Hexagon Nutrition Limited, along with Indian Dietetic Association Mumbai chapter, an academic partnership from Kenya Medical Training Center. Today's topic is on nutritional management of critically ill patients, and we're going to focus on polymeric versus semi-elemental diets. Now, the importance of nutritional support in a clinical setting or in critical illness in the ICU is well established. However, there is a lot of research that is emerging, which is, giving us diverging conclusions, such as your EAT ICU trial or the Target trial, which gives you a different perspective about nutrition in critically ill patients. A lot of these variations are reflected in terms of differences that you see in clinical guidelines, in clinical practice across national and international bodies. For example, ESPEN tells you that in a critically ill patients, you need to start parenteral nutrition sooner, whereas ASPEN or the Canadian physician guidelines suggest that you give a chance to enter nutrition and you need to start parenteral nutrition much later. Critically ill patients, we understand they require a lot of nutritional support and a lot of titration in terms of the calorific need and the protein needs. You see a lot of muscle breakdown, and in a sense that leads to a decrease in strength and affects the quality of life of these patients. So careful planning of medical nutrition therapy in critically ill patients, knowing how much, at what time to start, and what should be the modality to, or the feeding route is very, very important, and it is associated with good clinical outcomes. So overfeeding and underfeeding is both associated with poor nutrition outcomes, and therefore here we have today's. So let me just quickly take this opportunity to introduce my dear friend. But before we start the session, let me reiterate the rules. The certificate of attendance will be given for all those who attend all 10 sessions, followed by an objective test. Attendance for the complete session is mandatory for all sessions. An objective test will be a 100 marks test, which will be given via Google form, and it will be sent to you on 1st of March 23. Minimum 80% is required to pass the test. Feedback for all sessions is mandatory. A feedback link will be posted at the end of the session. Those of you who attended last session and did not get the feedback link, I'll be posting that as well. All comments, suggestions can be posted in the chat box. Please limit the questions to the Q&A section and comments on the chat box. Those attending from the YouTube link will not be eligible for the certificate. So I'm honored to introduce my dear friend, Dr. Anagha Palekar. She's a senior dietitian at BYL Nair Hospital, Mumbai. And she's going to talk on nutrition management of critically ill patients, polymeric versus semi-elemental diets. She's an RD with and a certified diabetes educator with a PhD in social sciences from Tata Institute of Social Sciences, Mumbai, and also an LEC member of Indian Dietetic Association, Mumbai chapter. She's a faculty at various colleges across Mumbai and also a speaker at various national and international conferences as well. So Anagha, I welcome you to deliberate and today.
Thank you, Sukkada, for the kind introduction. Without wasting much time, I will start sharing the screen. So, good evening, everyone. Over here, I would like to begin the presentation where we'll be discussing about nutrition management of critically ill patients. Okay, so intensive care unit is a multidisciplinary team, or at times it can be a highly challenging, complex, or a stressful work environment that involves interprofessional team functioning. So in ICU, otherwise also, but in ICU specifically, we are working with a team of intensivists, with a physician, a nurse, a physiotherapist, a social worker, pharmacist, and we as dietitians are part of it. Teamwork in intensive care unit involves leadership, decision-making about what to feed, how to feed, not only from the dietitian point of view, but other people also taking decisions from the nutrition point of view. Communication about decisions that we are going to take about patients with the entire team, and whatever decision that we are going to take about, or for example, whatever nutrition intervention that we want to plan, whatever diet regime we want to begin, we also need to coordinate it with other team in order for it to get implemented just as we plan. So working in an ICU can be challenging, yet at the same time, it involves working as part of a team and getting the best for our patients. So who needs ICU admission? So first of all, different types of systems. For example, disease, right from the disease of cardiac systems such as a MI or a congestive cardiac failure or rheumatoid heart disease or disease involving arrhythmias may need intervention. Patients with bradycardia, that is heartbeat slow to tachycardia, might require hospital admission. Various disorders of respiratory system, for example, COVID, has been one of them. But at the same time, acute respiratory distress syndrome or exacerbation of chronic pulmonary diseases, obstructive pulmonary disease may require admission in the ICU, where the respiratory rate going very high or going very low and patient requiring ventilator support may also need, of course, need ICU admission. Neurological disorders can be as much, something like acute stroke, or it could be an autoimmune disorders of neurological systems such as Guillain-Barré syndrome, where the patient requires ventilator support, or it could be viral meningitis, okay, or it could be a hemorrhage, okay, drug ingestion or drug overdose or poison ingestion as something as snake bite or drowning may also require ICU admission. Gastrointestinal disorders such as, say, inflammatory bowel diseases with bloody diarrhea leading to sepsis, or sometimes severe necrotizing pancreatitis, or disorders such as severe hematomasis, that is vomiting or GI bleed, leading to ICU admissions. Various endocrine disorders, one of them is diabetes, ketoacidosis, or thyroid crisis. Okay, many patients who undergo surgery, after that, if they are critical, that is, or they have hypotension or low blood pressure or some complication or require ventilator support, may need ICU support, and other disorders may also require ICU admission. Now, the slides or the thing that I'm going to talk now, as all of us are practicing dietitian, I'm sure you all are aware about this, but just to touch upon and give some foundation to this talk. Significance, why nutrition is very, very important in ICU. All of us know malnutrition is prevalent in as much as 35 to 50% of the patients who are admitted in ICU. As much as 1/3 are malnourished at admission, and 2/3 of them can become malnourished due to lack of nutrition support. Hence, it is very important to have good nutrition support right from day one of admission in the ICU. Now, what could be some of the causes of malnutrition? It could be prolonged starvation, the patient being either going from one hospital to the another and then finally landing in the ICU. Or it could be because of the illness, the patient is not able to eat adequately for past 1 week, 2 weeks, or it could be anorexia, loss of appetite. As you know, critical illness involves a lot of catabolism, and that catabolism is probably mainly due to excessive catabolic hormones such as glucagon, epinephrine, norepinephrine, which increases the protein breakdown, fat breakdown, leading to catabolism. That also leads to malnutrition. And the hormone which actually builds up muscles, such as insulin, there is a resistance to insulin in critically ill patients. So therefore, there is more catabolism and decreased anabolism that can lead to also malnutrition. Many of the patients in ICU may be presented with nausea, vomiting, diarrhea. That could also, the gastrointestinal symptom can also lead to malnutrition. And then various procedures can actually prolong eating. That can be one thing. And then various protein breakdown from traumas or common drugs such as steroids, or loss of nutrient from diarrhea, vomiting, polyuria, wounds, okay, that also can lead to malnutrition. And above all, because the patient is critically ill, the nutrition needs are more. So therefore, that also, so if you're not able to meet the nutrition need, we can go in negative calorie balance. So that could lead to malnutrition. And as we know, if the patient is malnourished, it kind of has an adverse impact on the outcome of the patient's disease. For example, it affects the wound healing, it affects the immune system, increases the risk of sepsis. It actually leads to muscle wasting, which can affect each and every system, right from the respiratory system with cardiac system leading to difficult time in weaning the patient, removing the patient from the ventilator. Okay, so that is also one of the consequences. Muscle atrophy could happen, and our gut maintains our immune system. So gut integrity is very important. But if there is malnutrition, it can actually impair the gut integrity. It can actually increase the permeability, and that could lead to sepsis and bacterial translocation. Not only that, pneumonia is there, and it increases the length of ICU stay and hospital morbidity. And then, as you can see it in the slide, when there is good amount of nutrition support, all of these can actually be reversed, and all of these can improve the patient outcome in the ICU setting. So medical nutrition therapy should be considered for all patients who are going to stay in the ICU, mainly for more than 48 hours. Okay. Now, these are some of the decisions that we need to make as dietitians in the ICU. It could be when to start feeding, how much to start feeding, as Sukhada said in the intro, method of administration of the feeds, what are the routes of feeding, choice of supplements, whether we are going to use a polymeric formula or a semi-elemental formula, and how are we going to monitor the progress. So as dietitians, we have to plan all these things, but in order to find our answers, we have to perform the following things, right from nutrition screening to nutrition assessment, nutrition diagnosis, nutrition intervention, and nutrition monitoring. So nutrition screening, I'm sure you must be aware, but it identifies the patients who are at risk of malnutrition, and this helps us to start following the nutrition assessment and intervention earlier. Yeah?
Sorry, intervene. Could you go a little slow?
Oh yeah, okay, I will do that. So nutrition screening identifies patients who are at risk of malnutrition. Okay, as I said, malnutrition is very common, but in order to start the intervention, we need to first figure out who is at risk of malnutrition. So there are many established nutrition screening tools. One of the most common nutrition screening tool is subjective global assessment, as called the SGA, which is approved in critically ill patients. Then there is nutrition risk screening 2002, and then there is Nutrix score, out of which the basic components of most of the nutrition screening tool is what is the weight or the BMI of the patient, history of weight loss, has the patient lost weight significantly, which could be 5%, 10% in last 3 months, 6 months. Has there been any change in the food intake? Okay, whether the food intake has declined, whether there has been any decline in the consistency, for example, from a normal solid food, is the patient now having liquid foods or semi-solid foods? And what is the severity of the disease? Based on these factors, we can identify patients based on scores are given, and you can classify the patient as mildly malnourished, moderately malnourished, and severely malnourished. So here you can see subjective global assessment as one of the screening tools. Another screening tool is nutrition risk screening, NRS 2002, which takes into account the BMI, the weight history, but also takes into account the severity of disease. So it's a good one. And then there is Nutrix score, which is again recommended in the ICU, but it involves other scores as well. So even if you are able to use SGA and NRS 2002 as nutrition screening tool in the ICU, it's more than enough. Then moving on to nutrition assessment, which is going to be based on nutrition screening. So here now we have to be more in depth, because here we are going to collect relevant information about our patients and interpret this data in order to come out with decisions about the nature and cause of nutrition related problems. So nutrition screening and nutrition assessment are different. Nutrition screening is where you identify who is at risk of malnutrition, and the nutrition assessment is exclusively done by a dietitian, in structured assessment done by health professional, where we can actually identify who needs nutrition intervention. Now, let's go quickly into nutrition assessment in ICU. Now, in order to understand the nature of disease, okay, which organ is involved, whether it is cardiac, whether it is liver, renal, or to know how severe is the disease, to know if we are going to feed the patient orally, or if we are going to start tube feeding, that is enteral nutrition, okay, whether we are going to feed this patient through continuous drip, or we are going to feed this patient through bolus feeding, or a combination. These data, we can get an idea about these things by doing a detailed search about patients' present complaints, what are the patient's symptoms, What are the other diseases that the patient has, such as if there is diabetes, if there is hypertension, if there is IHD, there is cancer, what are other problems that we have to tackle as well, along with the present problems. Also, has there been any history of hospitalization, which also tells you patient may have, been chronic patients, so risk of malnutrition even more. And if this patient is on ventilator support and what mode of ventilator he is on. This is very, very important. So therefore, this data will help you get information about patient's general condition and the prognosis. These signs that you can see over here, okay? Remember the first question that I put, it is when to begin feeding, okay? And the answer is based on these vital signs, okay? So first, whether the patient is maintaining blood pressure or not, okay? If the patient is being given medicines which are called inotropes, which are given to maintain blood pressure in patient whose BP is dropping, is the patient's heart rate very high, tachycardia, or there is low heart rate, bradycardia? Is the patient's respiratory rate very high, tachypnea, as they say? Because in that case, the patient is really having maybe in respiratory failure, okay? And most importantly, is the patient having hypoxia right now? What is his saturation, oxygen saturation? That's something we need to know. And often in critically ill patients, especially in respiratory failure, the patient can be in respiratory acidosis. And in that case also, it becomes difficult to feel. You need to make the patient stable first. So based on these parameters, okay, if all these parameters are fine, and if the patient is hemodynamically stable, that term is very important. So if the patient maintains these signs well, and if the patient is hemodynamically stable, only then we can start feeding the patient. So as they say, as soon as the patient is hemodynamically stable. Okay. Also, one more factor, which is not really a vital sign, but it also talks about dehydration, or it also talks about sometimes organ ischemia, that is urine output. If the urine output is dropping also, again, not a very good sign. So based on this, you're going to decide how much calorie am I going to begin. If somebody is not maintaining blood pressure, we will start with lesser calorie or a hypocaloric diet. Okay. How frequently are we going to feed this patient to continuous drip? Whether if the patient is eating orally but very breathless, are we going to feed soft diet or a liquid diet? Or if the patient is maybe in dehydration or acute kidney injury, then we may need to hydrate the patient. All these signs are going to tell you a lot of important information, and you need to pay good attention to them. Apart from the first thing, most important thing is, as dietitians, we need to know what are the medicines given to the patient, and we should be able to connect with their symptoms. So if we look at nausea, vomiting, start looking for a drug which is given to control vomiting and antacid. If patient is in sepsis, what are the antibiotics that has been used? If patient has viral infection, what are the antiviral drugs given? If patient is diabetic, is he receiving or she receiving insulin through drip, or it is given as subcutaneous dose? Are there, if the patient has renal background, what are some of the binders or medicines used? So we need to be thoroughly knowing about what medicine the patient is on and accordingly modify the data. Along with that, we cannot ignore the clinical signs. If you want to know if the patient is at risk of malnutrition, start looking for loss of fat loss and muscle loss signs. If there is chronic micronutrient deficiency, look for pigmentations, abnormal coloring of the skin, hair texture. If you are suspecting liver or renal abnormalities or cardiac problems, the patient may have generalized edema, pedal edema, increase or decrease urine output. If patient has neurological problems or say meningitis or infection, the patient, or in sepsis for that matter, or any respiratory thing, patient may be confused, agitated, easy conscious oriented. If the patient is agitated, altered, not in his senses, you cannot feed him orally. You have to put an RT. So this will tell you what is going to be your feeding strategy. Okay, and urine output and blood pressure and overall communication with your team will also help you decide your fluid requirement. Biochemical parameters, well, I'm not going to take out too much time over here, but a complete thorough blood count, liver function test, arterial blood gases, which are very, very important in respiratory disorders, amylase lipase, fever profile, tropical countries, malaria, dengue, lepto, very, very common. These may make a patient go in ICU with acute respiratory distress syndrome and multi-organ dysfunction syndrome too. So these need to be checked. Other specific markers, I mean, in cardiac ICU, you may often see TROP-T test. In COVID, we saw a lot of D-dimer tests, which indicates or there may be pulmonary thromboembolism, presence of clot. In viral infections of brain, we might see cerebrospinal fluid use. Many times in lung diseases, we might see pleural fluid. In liver disease or other malignancies, there may be abdominal fluid or ascitic fluid checked. So we need to check all these investigations. These are some of the most confirmatory investigations that is used in ICU along with the other investigations, which will tell us about functioning of different organs, and that needs to be checked too. Now, based on that, all this detailed information that we have derived from the patient, we have come to the final question of when to start feeding. Okay, so as I said already, initiate feeding when the patient is hemodynamically stable. He's maintaining his blood pressure, he's maintaining his heart rate, he's maintaining oxygen level, he's maintaining his respiratory rate. Okay, then he's stable. Confirm that with a physician, and then we have to start feeding. So earlier this is say 0 hour when hemodynamically stable. Oral diet should be preferred over enteral nutrition anytime or parenteral nutrition in patients who are able to eat. So not all patients in ICU are going to be on enteral nutrition, but there are going to be patients who are going to be eating orally, and for them, oral diet is the best preferred route. But if oral intake is not possible, then early enteral nutrition within 48 hours in critically ill adult should be performed rather than delaying enteral nutrition. We should not waste days in, waiting for patient to eat. But if we realize that's not happening, start enteral nutrition. Oral intake is not possible. If oral intake is not possible, then early EN shall be preferred. So always remember EN preferred over PN, but start early enteral nutrition. How much to feed? Simple, 25 to 30 kilocal per kg. So of course there is indirect calorimetry, but practically prediction equations 25 to 30 kilocal per kg present body weight can be used. Always start slow. Do not, so go into hypocaloric feeds. Do not exceed 70% of energy requirement in early phase where the patient is not really that hemodynamically stable, but not that out of very severe critically ill. But after 3 days, okay, you can meet the calorie requirement up to 80 to 100%. Okay, but patients who do not tolerate EN in a span of first week of ICU admission, only then you can think of weighing the safety of starting parenteral nutrition. So we are going to try our best strategies to feed the patient enterally, but if that's not happening, then we will have to switch to parenteral nutrition case by case basis. So first, always use the gut or we will use it. During critical and parenteral nutrition should not be started. Okay, we've mentioned that. During critical illness, 1.3 gram per kg protein requirement per day can be delivered progressively. In some cases, to be honest, we have used even higher than that. We should use higher than that because prevalence of malnutrition is there. I have put anthropometric assessment much later, though it is part of assessment, because one of the common question is how to decide which weight to use. Ideally, use their usual weight if it's documented by checking with the relatives that what is their usual weight. That is because in ICU, you might see patient with edema, with bandages, with drains. So it's difficult to really assess their weight. So if that weight is not available, and if their height is documented, calculate the ideal body weight and do your calculations. Again, in case of obese individuals, we cannot use their present weight to calculate energy requirement or protein requirement. So to be realistic, we can again document their height, get their ideal body weight, and calculate their energy requirements. Or if the patient has been on dialysis, check out their general dry weight and use that weight as their usual weight. And then there's a formula which is called adjusted body weight, where you can take a adjusted body weight. But ideally, I would recommend use a usual body weight or calculate their ideal body weight. These are the 3 routes of administrations of feed in an ICU patient. Patient who are able to eat. This could be a patient with a myocardial infarct, or it could be a patient with chronic obstructive pulmonary disease, who's able to eat with nasal oxygen support, or it could be a patient with dengue. So oral feed is possible in these patients. But in these patients, if they are not able to meet their calorie requirement, we may need to add oral nutrition supplement. And while feeding the patient, depending on breathlessness, depending on symptoms, we may need to adjust the consistency and food frequency. Enterally, Sukada has already excellently explained the types of the feeding methods available, that is bolus feeding, continuous drip feeding. I have put this one actually, as per the guidelines. It's mentioned that continuous drip method is one of the most preferred method of feeding in an ICU, considering it improves the GI tolerance mainly, and it reduces the risk of aspiration as per this thing. However, if your setup allows you to have continuous drip as one of the methods, and if your setup allows you to have use of exclusive commercial formulas, then continuous drip, okay, you can try. But if the setup does not allow you to have a continuous drip, you can use bolus feeding as well. And you can adjust the frequency and quantity and volume that you're going to use. You can start with a lower volume and increase frequency, like 100 cc 3 hourly, and then gradually move to lesser frequency and more volume as per patient's prognosis. And in some cases, we can also use combination of continuous drip and bolus. So that also can be used. Okay, and then of course, we'll not do too much of this, but as I said, if patient we cannot feed within a week, we can start them on partial parenteral nutrition or total parenteral nutrition. So the question is, what is going to be our choice of formula, choice of feeds in these patients? So as I said, there are three options: exclusive commercial formula, wherein you use only the commercial formula to meet the patient's energy and protein requirement. If you are in a setup where you can use this, you have enough resources and finances or cost is not a problem, you can go ahead with this option. But suppose if in my case, I come from a setup where I may not have the resources or the financial distinct to give exclusive commercial formulas, then I can choose probably in-house formula. Or the best way you can do, okay, so though in-house formula, one of the reasons they're criticized is because probably they may not be hygienic, or they may not be bacteriologically safe. They may have higher bacteria count, etc. One option is they make them fresh. You take all the safety measures and aseptic precautions to prepare these formulas, and you can use for the patients if you do not have the option of using commercial formulas. Or you can go through a midway where you can meet a combination of commercial formula or in-house formula. And all of these strategies can give you the best of results. It all is a matter of resources that you have and the setup that you have. So feeding should not stop because I don't have commercial formulas. We can always make the provision of in-house formulas prepared in the most hygienic way and the acceptable way to get the best of results, but it's a combination. I'm not going to spend most time on polymeric formulas or standard formulas, but you know polymeric formulas are the one which are intact formulas. Okay, they are their osmolarity is physiological as good as in your system. But believe me, they can be used for all the above disorders. Okay, as long as you have got a functional digestive system, for cardiac, for diabetes, for stroke, for mechanical ventilation, for liver, renal disorders, polymeric formulas or intact formulas are best tolerated as well. Only thing is, depending on the patient's severity, depending on the patient's diagnosis and how he's going to progress, you can decide whether this formula, how are you going to give through continuous drip, through bolus, all that you have to decide. Let's take a quick scenario. A patient, I'm not going to spend again too much time, but the patient with myocardial infarction, okay, he's not had too much of starvation. His intake is reduced since he's been admitted because he has chest pain. Critically, if you see, he's got an intact GI tract, no history of GI intolerance, and no history of starvation. You can straight away give this patient a polymeric formula as oral nutrition support to meet the energy required. So here give a polymeric formula which is intact. Scenario 2, 65-year-old female or male, but he is admitted with altered sensorium. Okay, is not really that conscious oriented. Heart failure with the low ejection fraction, And they have put a RT for him, and he's got a fluid restriction as well. And they have put medicine to maintain blood pressure. He's stable now. In this patient also, if you look critically, functional GI tract, no GI intolerance, no history of starvation. What you can do is you have to feed him through tube. First option, start with continuous drip, a polymeric formula, intact formula, okay, at 30 cc per hour, then move to 60 cc per hour. If no facility of continuous drip, reduce the volume, increase the frequency, and start bolus feed to begin with. That is 100 cc 3 hourly, and then move gradually. And if that is also not available, then you can use kitchen feeds or in-house formula, same frequency, 100 cc 3 hourly, to maybe then gradually improve as the patient gets better. So in this case also, you can use a polymeric formula. Now, just to give a second perspective, in the same case, but if the patient is 85-year-old male with history of chronic starvation, with heart failure, on RT feed, then I might just think maybe one of the possibilities, and we have tried this in aged patients, is that is considering the age factor, but no other thing, we can consider both polymeric as well as a semi-elemental formula. Semi-elemental formula is a pre-digested formula where the proteins may be present as peptides, dipeptides, MCTs, and fat is as an MCT. And same thing we can give, but if your setup does not allow commercial formulas, we can go back to the previous case and do the same thing. So all I'm trying to say is, similarly here, COPD patient, okay, breathlessness, on mechanical ventilator, feeding through Ryle's tube, moderately malnourished, okay, determine the calorie, protein requirement, carbohydrate requirement, be thorough with your MNT, decide what are the respiratory nutrient important, what are the fats that I'm going to use. Start with, if possible, this is an ideal scenario. Start with continuous drip, exclusive formula, okay, 30 cc, 60 cc, monitor how the patient does. Once the patient gets better, is weaned gradually from the ventilator, meet your requirement of 25 to 30 by end of 1 week using exclusive commercial formula, and then gradually shift the patient on bolus feeds and start using even your kitchen feed as the patient gets better. But if your setup does not allow, you can start right from kitchen feeds from day one, but at a smaller volume and higher frequency, and gradually check how the patient does and move. Okay. Semi-elemental formula, as you know, are pre-digested formulas, which are, so as the term suggests that, yeah, whenever there is, their nutrition be complete, but whenever the gastrointestinal tract probably is not intact or compromised, or the digestive capacity or the absorption is affected, or if there is malabsorption, that is when we are going to require semi-elemental formulas. Technically, theoretically, they'll be more readily absorbed in the upper intestinal tract, leading to complete nutrient absorption and less stool residue. However, the more you break the molecules, the more you also increase the osmotic load. So one of the complications, or one of the problems that we might see with semi-elemental formula can be osmotic diarrhea. But again, it's one of the complications. Okay, and also the more broken a formula is, the less is the taste. So acceptability can be different, but in tube feeding doesn't matter. One of the major components used in semi-elemental formula is whey protein hydrolysate, and I won't take too much time. But why semi-elemental formula may work well is because it contains whey protein hydrolysate, and it contains all the following things, which are anti-inflammatory, antioxidant, immunomodulating, improve the muscle strength, and protect your organs. So good in critically ill patients. They also reduces the suppression of inflammatory cytokines, therefore good in preventing organ injuries. They also improve your immune system, the gut-associated lymphoid tissue, which gives you the protection to the gut system, immune system, and it also improves your microbiome. Okay, so, and most important, since it is in the broken down form, it is absorbed or facilitated faster, and GI absorbance or gastric emptying becomes faster. So these formulas are better tolerated. But as the evidence or the guidelines say, no clear benefit to patient outcome with semi-elemental formula, and the recommendation is to use polymeric formula in critically ill patients. So which is to an extent true that you can use polymeric formula, and case by case, you can decide which semi-elemental formula, in which cases you can decide based on your clinical judgment. Okay, short bowel syndrome, where the length of your small bowel is less than 180 to 200 centimeters. So obviously there is going to be risk of reducing the absorption surface, jejunal and ileal dissections. Almost 40 to 50% of the bowel is resected. It could be due to Crohn's, it could be due to malignancies, it could be due to radiation enteritis. In children, it could be present from birth. So that's also, many studies are done in children, or it could be intestinal damage at the time of birth. So obviously there's going to be malnutrition, malabsorption, leading to malnutrition, dehydration, because maximum amount of fluid absorption happens there. Of course, in the colon as well, but also in the small intestine. So here, there are studies which have shown or compared semi-elemental with polymeric formula, but conflicting results. Both studies showing. So of course, in short bowel syndrome, you have to begin with parenteral nutrition and gradually in the adaptive phase, start introducing the enteral formulas. So in that case, again, there are conflicting studies, which some says no difference in the, calorie absorption or nitrogen absorption. But some studies do say that, yes, they were beneficial. So again, here you have to take your own judgment. But if given a chance, you can begin with semi-elemental here. And as the intestine adapts, you can move to polymeric formula. Inflammatory bowel disease, well, as you all know, inflammatory bowel disease comprises of Crohn's disease or ulcerative colitis. And so when the patient is admitted, he's in flare, or where the disease is very active, where the patient has symptoms of bloody diarrhea, persistent diarrhea, vomiting, it's a highly inflammatory stage. And technically, if you look at it, the peptides in the medium chain triglycerides increase the digestibility, protect the mucosal integrity, and it improves the nutrient absorption. Okay, and moreover, there are, as compared to elemental formula, which is only amino acids, glucose, semi-elemental are little better to taste. So studies have, however, shown no difference in remission rate, like how fast remission you go into, like how you get better between semi-elemental and elemental formula as well. However, there are many studies which are done, which indicate that when the patients are on semi-elemental formula or a pre-digested formula, when you have inflammatory bowel disease, it improves the disease activity, it reduces the frequency of stool, it improves the BMI, albumin level. So yes, there are conflicting studies, but if you ask my experience, or in our experience as a team of dietitians, we have used both polymeric as well as semi-elemental formulas, and both have worked well. So standard EN guideline says standard enteral nutrition polymeric moderate fat formula can be employed in patients with inflammatory bowel disease. Okay, no need to start a semi-elemental formula. Now we'll go to one of the last. There are many indications, but I'll touch upon only these. Pancreatitis is a very common condition, and it is studied a lot for use of semi-elemental or peptide-based formulas. So you can see a healthy pancreas, you can see an inflamed pancreas, and as you know, the moment you start food from the stomach, it reaches the duodenum, it stimulates the pancreas to produce the pancreatic juices. Now, when the pancreas is inflamed, okay, when it's inflamed, it releases, then it undergoes auto-digestion, it could undergo, necrosis. Now, in such case, if the patients are fed in the stomach, then when they reach duodenum and the pancreas is contracted, it causes lots of further inflammation, pain. So earlier, always this thing was to give rest to the pancreas. Okay, so do not stimulate the pancreas, give rest to the pancreas, and put the tube not in the stomach, but okay, patient with acute pancreatitis can also be fed orally if they are having a mild pancreatitis. But in moderate to severe necrotizing pancreatitis, which is very severe, the patient is always first kept NBM, nil by mouth, and then fed through a tube. But there are again two things over here. Some studies have shown when the tube is placed in the jejunum, you do not stimulate the pancreas, you give rest to the pancreas and feed the patient in the jejunum. In the jejunum, as generally the food comes in a pre-digested form, it makes more sense to give the patient semi-elemental formulas, which are broken formulas or pre-digested formula, which are absorbed better, and you can feed them through continuous drip. So in pancreatitis, that has been the thing where you feed the patient in NJ, nasojejunal, and use a semi-elemental formula, and it gives good results. Okay, which is true. However, there is a certain set of studies which have been done in patients with pancreatitis who have fed the patient directly in the gut also, in the stomach, okay, and fed polymeric intact formulas and still have got the similar results. So, semi-elemental formula, okay, in pancreatitis, some studies have shown less weight loss, lesser hospital stay, okay, and reduction in inflammation by reducing C-reactive protein and less septic complications, and reduction in mortality. Okay, so one study, however, which involved quite 428 patients by Petrov et al. Showed PN as a reference in that study was used. However, no difference regarding tolerance in rate of infection and mortality between both polymeric as well as semi-elemental formula. So again, there are conflicting results. And a recent meta-analysis including 15 trials involved 1,376 participants showed no evidence to support any special or specific NT formula, whether it is polymeric or semi-elemental. So here we get conflicting results. But I can say what we do in our center, I'll just show you in the example. So final guideline is standard polymeric diet, administered via nasogastric tube. Again, no special recommendation for jejunal, but jejunal tube preferred in case of severe gastric intolerance. So only if there's a gastric intolerance, you can give nasojejunal, or you can stick to nasogastric. In patients undergoing minimal invasive necrosectomy, that is removal of the necrosed part, who are unable to feed orally, in them only you can give jejunal feeds. So yes, you can take that judgment. There have also been cases when the patient with pancreatitis with diabetes, we have fed them on polymeric formulas and they have given excellent results. Okay. And at the same time, in some patients with pancreatitis, when we have used semi-elemental or pre-digested formulas, it has also led to sometimes diarrhea initially, and then patients have settled and done well. So I'll just take you through one. I'm just come to the end of the talk. 45-year-old chronic alcoholic is one of the major causes of pancreatitis, presented with fever, severe abdominal pain, nausea, vomiting, raised amylase and lipase and WBC count. CT abdomen shows acute necrotizing pancreatitis. Patient was NBM for 4 days, received IV, severely malnourished, poor oral intake, and has already lost more than 15% of weight. Okay, now the patient was fed through engine. So first, always thumb rule is what? Calculate your energy, decide the protein requirement, decide the fluid requirement, keep everything, your micronutrients, macronutrients ready. Once you have a thing ready, then you are going to decide first how much, when is decided. Now hemodynamic is stable. How much is decided. Then you will decide which route NJ decided. Then which method, so continuous drip or bolus, and then which formula to use. So continuous drip here, what ideally we can do is use initially to begin with a peptide-based formula. You can start with 30 cc, then move on to 60 cc per hour. Then as the patient gets better, we can start with 100 cc per hour. Okay. Now, when you realize that patient has now tolerated peptide-based formula better, you can move to now a polymeric or intact formula. Okay, because let me also tell you, peptide-based formulas are a bit expensive as compared to polymeric formulas. So it's get economical for patients also from shifting to a semi-elemental to a polymeric formula. So first start with peptide formulas for 3-4 days or 2-3 days. Then as the patient gets better, you can shift the patient to a polymeric formula. Okay, and then give them trials of continuous drip plus bolus. If that is tolerated well, move to in-house kitchen formula plus commercial formula bolus. Once bolus feeds are tolerated, doctor, we can communicate. Always communication is the key. So communicate about starting liquid diet, move to soft diet, move to full diet. Now, here again, there are going to be a lot of problems in terms of the practical problems. Now, in this case, if one did not have the facility of continuous drip, or if you just had a facility of commercial polymeric formula, you could have started on a polymeric formula to begin with at a lesser volume, okay, and more frequency, and then gradually increase and meet your requirement as per patient's tolerance, and then initially and then gradually start fixing formulas. But if you did not have the facility of commercial formulas at all, you could have started on clear liquids through bolus 100 cc 3 and then gradually progress to meet your requirement as per your setup, as per your resources, as per the condition of patients response to the treatment. So while doing all this progression, monitor based on amylase, lipase, check the WBC count, be in touch with the doctor, okay, see the pain relief, diarrhea episode if any, okay. So once we know, we have to basically know one thing very clearly. Guidelines should be always taken like a, you can say a backbone sort of a thing, but no, like a reference, I would say. Keep your guidelines as a reference. They tell you what to do, how much to do, when to do, but guidelines and actually practicing and being in a situation where you have to handle a live patient are two very different things. And therefore, we need to be very clear about what are the resources that I have, how I can make most available for example, in commercial resources, I can get it done through some schemes, government schemes, if I can get them sanctioned, if I can get them sanctioned through social worker, okay, and if I'm going to use it partially, can the patient afford it? Based on that, you are going to decide your strategies. So ideally, yes, continuous drip, commercial formulas, but try to find a midway, what suits your setup. But whatever you choose to do, make sure that it is done most hygienically in an aseptic manner, and you follow patient well, you evaluate and monitor patient well. So while doing all this, monitor the improvement of markers, like if the patient was having hepatitis, has he improved? Any cardiac improvements? How has the feed been tolerated? Okay, meeting target should be individualized. So 80 to 100% in first week. But if your patient never had starvation, you can meet the requirement early also. So it's very individualistic. Plan every individual's diet separately. Okay, cannot apply one chart to all the patient. Nutrition assessment mandatory at each step. Make your own feeding protocols. Okay, set your gastric residual volume protocols. Okay, how frequently you want to check, whether you want to check, and what you're going to stop. You need to decide that with your team. And set aseptic protocols for in-house formula and keep them as fresh, make them as fresh as possible. So with this, thank you so much for your patient listening. I really, really appreciate. I'm sorry if I've crossed my my time. Yeah, Sukhada. Sukhada, are you there?
Yes, ma'am. I'll be taking over here. Yeah. So thank you so much, ma'am, for an excellent session. So we'll start with the panel discussion now. So should we take up the questions? I think we'll start pouring in. So just a minute. So the first question to you, ma'am, is on just a minute. What are the reasons you would choose a semi-elemental diet or polymeric formulas? Do you feel polymeric formulas work equally well as per semi-elemental, or how do you justify the usage?
That's to me, right?
Yes, ma'am. Yeah.
Okay. So as I said, it's very, very case specific. Okay. So to be very honest, I have used semi-elemental formula particularly in GI surgeries. Sometimes post-abdominal, very rarely again in post-abdominal surgeries, mostly in pancreatitis. Yes, we start with peptide-based formulas, but we have also used polymeric formula in pancreatitis. And even sometimes in pancreatic cancer, when the patient undergoes Whipple surgery, when the patient is on jejunostomy field, in some cases, yes, we have started the patients on peptide-based formulas and then progressed to polymeric formula very soon. So it depends that way. Similarly, in a few cases, for even elderly patients in ICU in sepsis, when we had semi-elementary formula as some of the, I'll be very honest, samples, we have used those and checked how effective were they, and they have been quite effective. So it's been a very, very case-specific approach, but most of the otherwise patients where, whether in medical ICU, I would say, or in neurosurgical ICU, we have used polymeric formula exclusively, and they do very well and equally good.
Thank you so much, ma'am. So we also have our eminent panelists today who have joined the session and who will be also sharing their opinions with us today. So I will take this point to introduce our panelists for today. So we have the next slide, Sudha. Yeah. Yes. So our first speaker, I think already Dr. Anagha Palekar will also be one of the panelists for today's session. So I think Sudha has already introduced her. So the next panelist for us today is Dr. Daphne TK. She's a Chief Clinical Dietitian, Apollo Main Hospital, Chennai, and she's done her PhD in Clinical Nutrition at Department of Home Science, Women Christian College, Chennai. She has a rich experience of 26 years in clinical experience at Apollo Hospitals, Chennai. She's a course director, Apollo Clinical Nutrition and Dietetics Internship Program, and she's member of Board of Studies at University of Madras. She has various awards and recognitions to her names, and she has been a reviewer of Journal of Parental and Enteral Nutrition, Journal of Human Nutrition and Dietetics, and she has few national and international publications to her name. So we welcome you, ma'am, to be one of the panelists for today's session. Our next panelist for today is Ms. Stella Nambuze from Demurila. She's done her BSc from University of Eastern Africa, Barrett in Kenya. She's a candidate for MSc at Kabarak University, Nakuru. And she's done her post-graduation in pediatric nutrition from Boston University School of Medicine. She currently has an 5 years experience in clinical nutrition, and she's working with Nakasero Hospital. We welcome you, ma'am. Our next panelist for today is Mrs. Varsha Gori. She's a senior clinical dietitian, HO Dietetics, Apollo Hospitals, Navi Mumbai. She's done her MSc in RD, and she's an IAPN secretary for Navi Mumbai chapter. She has a rich experience of 25 years in the field of nutrition and dietetics with more than 13 years experience in hospital. She's completed her SPIN LLR certified programs in 14 subject modules and also done her food map diets from Monash University. She's contributed to 2 chapters in Book of Clinical Nutrition, GI Diseases and PCOD, released by Apollo and in Clinical Nutrition and Cancer. We welcome you, ma'am, again today for the panel session. Our next panelist for today. Okay. So I think, yeah, that is all we have for today. So thank you very much and welcome you all for today's session. So taking up the next question for the panel today. It is for Ms. Daphne, Dr. Daphne, sorry. So is there a need for disease-specific formulation in critically ill ICU patients? What is your opinion on that?
That's a very nice question. I think Dr. Anagha was speaking a lot about it. And we normally see guidelines say that we don't require a disease-specific formula. A normal standard polymeric feed is perfectly fine. But in clinical setting, if you see, we do come across different case settings wherein, maintaining somebody's sugar becomes a challenge, and diabetic formulas come in really handy to handle such situations. Though it may not really relate to a clinical outcome, but if you look at, fluctuating sugars, it leads to a poor outcome. So it may not directly relate to a disease-specific formula, but if you look at glycemic control, obviously it comes in very handy. And when we, talk about patients with electrolyte imbalance, even guidelines do specify that high-calorie, high-protein formulas with low electrolytes can be used, but it has to be the clinical judgment of the dietitian. So disease-specific formulas, appropriately, it can be used. It needn't be used in all critically ill patients. So it is the clinical judgment and the discretion of the dietitian. Say, for example, in surgical setting, this is the only setting wherein you do find guidelines advising you to use immunomodifying, modulating formulas. So you can use it starting from pre-surgical setting itself and through the surgery.
Thank you, ma'am. So continuing what ma'am just now said on hyperglycemia in ICU using a DM-specific formula. So my next question is for Ms. Varsha Gori. So how do you manage hyperglycemia in critically ill patients? How do you do it? Like if you have a patient with ICU which may behave like with diabetes, how do you manage the hyperglycemia?
I think the pace is set just right. Anagha gave a good background on critical care, and Daphne just pushed a point how critically ill patients will have different challenges. And one of the challenges, yes, is hyperglycemia. And we often hear that hyperglycemia, never the patient had this issue, but why did it happen? So first of all, we need to rule out the cause. There was no existing diabetes or there was under control. But suddenly, was it a stress base? Or was it related to any kind of medication, or it is a new onset? So we need to rule out the cause. Once the cause is ruled out, and we all know that a critical care team is a totality where the dietitian is going to work, endocrinologist, intensivist, and a physician or any specialist will be there. So depending upon this total team members, the insulin rate or the way the insulin is delivered will be known. While we are planning or when we have to give our inputs, it is essential to understand that we need to plan a formula which will cater to hyperglycemia. In our practice, I think you all can support and help me understand better, but I think continuous feeding formulas works better than the bolus feeding. So this is one point. If you have to look at the hyperglycemia control, we need to look at the way, because critical care, it's ideally beneficial that continuous feeding is there. Sugars can be well controlled, monitoring of sugars every 4 hours so that you know how the insulin is going, what are you feeding, because in our setup we are feeding every 4 hours, like continuous feed formulas goes every 4 hours. So monitoring is important. Then the next comes type of formula. How much overall calories are you giving? Of course, we will look into the low GI formulas, which will be low GI. On one side, you have higher requirements, but other side, if you are overfeeding, it will not work. So we have to step up. So these are the few points that you choose the formula, choose with low GI, look at a multidisciplinary approach, do not overfeed, monitor. Ideally in our scenario, continuous feed works better. So this is like what I would like to say.
Can I also add something here?
Yeah.
Yes.
Yes, Anagha.
Yeah. So again, yes, as ma'am said, continuous drip feed is one of the strategies also. But in our ICU, we also have a setup, of course, where the insulin is given subcutaneously. So maybe an active like 3777 or 888. And there are cases if you are not able to feed these patients to continuous drip. What we do is we do bolus feeding. And what we do over here is we calculate the requirement that we have to give, calorie and protein, and divide 60% of calorie as to be given before insulin. So 20% of calories are given before the insulin feed, and rest 40% are divided into the day throughout. And we call it fragmented RT. And that really works well, where you give 20% of your calorie before the subcutaneous insulin and recite the best. Now, why I'm telling this is because every hospital may not have the facility, suppose, of continuous drip. And if you want to give your formulas through bolus, then this can be one of the strategy where you calculate 60% as your major feed, we say, before insulin, three feeds, and rest you can give throughout the day. That also works really well. And very few complaints of hyperglycemia, and even hypoglycemia we don't see much. And here, what also I would like to add is in some cases, if the patient has fluid overload, which also happens a lot in cardiac failure, and you have fluid restrictions. In such cases, we have also used 2 kilocal per ml formulas and planned, and sometimes we have even used malt preparations to be given in these major feeds, and both work really well. So just to add to that.
Thank you
Yes,
so much.
of course. It's not about using only diabetic formulas. You can use high calorie, high protein formulas also, Anagha, depending on the fluid that we get. Otherwise, we may not be able to reach the target. I do agree with you that you do use bolus, but the first priority that we give in any clinical setting, especially in critically ill, is in ICU setting, it is continuous feeding. Maybe if it is not possible, then you can think of,
Yes.
bolus only. And
Yeah.
as you said, it has to be planned alongside with the endocrinologist to,
True.
adjust the dosages. It
True.
might work well. It cannot be totally on the dietitians to decide and just, flush
True.
it in. That doesn't work at all.
Absolutely.
So if they are in
That's
sync with the dietitian and the diabetologist, maybe it will work.
yes. That's what I meant. So if not, when not in continuous drip, you also have another way of planning your bolus feeds, which gives you equally good results. That's what I mean.
I think we got a good perspective of continuous bolus type of setup and good understanding.
Yeah, of course. It might help people who don't
Really,
have,
really.
Absolutely. Absolutely.
Yes.
Right, quite right. So I think now moving ahead to another one important aspect is what is called as proteins in the ICU patient. So my next question is for Dr. Stella. Most critically ill patients require a high protein diet. So how do you ensure that the dosage is right for every patient?
Okay, thank you so much. I thank the panelists, my colleagues out there. Thank you so much. Thank you, Dr. Anagha, for the presentation. Protein is really a great requirement in ICU because the patient, firstly, we don't know how long the patient will stay with us in ICU. So identifying their protein requirements is of paramount importance. I could give an example. If you admit a patient with more than 5% degree bands, definitely you know that you need a lot of protein and a lot of energy to see that you improve this patient's care. It's identified individually, can't depend on the person. Even in the earlier presentation, is clearly stipulated. You have to do continuous monitoring and assessment and initial assessment upon admission. Normally, as a nutritionist, I get a scare when I admit a patient and I really see that this patient is not doing well. I think my colleagues also can testify to that. You definitely know that alongside the illness that has brought them in, you have a lot of work to do to see that their protein intake, their energy intake is really paramount and met in the day. But also this is determined after the patient is stabilized, depending on how the patient came into the critical care unit. If they are still very unstable, yes, you can start to do your assessments, but then you gradually modify how much protein the patient needs as they improve. Because we know that upon admission, they are in trauma, and it's the first degree of trauma. So you have to first see how better they will feed, what mode of feeding, upon which your meals will be planned. For instance, if the patient won't be able to use his enteral route, you definitely know that you're going to use the parenteral route, and you have to calculate how much. You have to know how much volume this patient is going to put out. Do they need a nephrologist on board? Are they in cardiogenic shock? So all these are key and paramount on how much protein the patient needs, and are they able to utilize it then upon admission. But a nutritionist role is to see that you continue assessing the patient, but earlier initiation of adequate protein is key and paramount as per the body weight of the patient and the disease state.
Any other panelists would like to add on?
So, when we talk about critically ill patients, I do agree with Dr. Stella. It can be individualized, but, to give you a rough idea as to how we can start as minimum as 1.2 grams, and it can go as high as 2.5 grams per kg body weight. Whenever we talk about critical illness, give a lot of importance to the protein. Anagha did walk us through about hypocaloric feeding. Starting first 48 hours, it can be 70% of the targeted requirement, but there is no guidelines which tells you to give 70% of protein. Always try to aim higher protein because they become so wasted. They become, thoroughly down by the week. So ensure that you plan high protein feed for them, though calorie can be little less because they do get endogenous glucose from the system for the first 48 hours. By day 3, it is 80%. And by day 5 to day 7, you can meet the targeted goals. So at least 1.2 should be your aim.
Okay, ma'am, continuing on the fact what you spoke on the proteins and energy levels, like, so coming to the fact, like when the protein and energy requirements go quite high, there is an aspect of kilocalorie to nitrogen ratio. So in most hypocatabolic states, the kilocalorie ratio is maybe lower. So how do you tackle it? And what is the significance of kilocalorie is to nitrogen ratio?
Kilocalorie is to nitrogen ratio. It may not be our cup of tea, and it may not really, give us much, there is no major evidence or in practice, that's what I'm saying. In ICU setting, there is limited use to that. We may not sit and calculate, how much of calorie is to nitrogen we are planning. While prescribing, the doctor may not look at that. But in general, the proportion should be between 70:1 to 100:1. By and large, this is between the non-protein calorie is to nitrogen ratio. 70:1 is to 100:1. By and large, if you calculate, when are you expected to calculate when your patient is not thriving? So you get to understand where are you going wrong. So people try to do nitrogen studies. That's also a tedious process. In that case, you can calculate this non-protein calorie is to nitrogen. If you by and large calculate and see, if you have a total energy requirement of 2000, the appropriate protein should be around 125. So if you minus around 500 calories, it is around 1,500 calories from the non-protein calorie is to 125. Are we reaching such targets? That's what you roughly have a look at. Okay. But practically speaking, that doesn't work in clinical settings.
I have something to add. Of course, I agree with what Daphne said. Theoretically, we all learn this way. When we try to practice, calculate, we do. But one more advantage which we come when we are talking with commercial formulas, it is so easy because when we go back and calculate, like she mentioned, the ratio equally fits. The formula are designed in such a way that the ratio of non-protein calories to protein will match. You can try, and then what best suits, then you can see whether it is suitable for your patient requirements or not. So that is our theory.
That's what I said, Varsha. Whenever we find people who are not thriving well, then we tend to do a lot of, root cause analysis as to somewhere are we going wrong. Yeah. Otherwise, as you said, any commercial formula, it will fit in this ratio of 70:1, 1 to 100:1. By and large, if we are between that range, I think we hold good for the patient.
Yeah, and I think sometimes even sometimes, I mean, again, I would not say, but even 100 to 130 also, especially not all patients are on entry fees, right? In oral also, you can meet the ratio pretty well, depending on the distance. So it's not always, what ma'am's saying is also in a way correct, but then approximately between even 100 to 130 of calories to nitrogen ratio, it is possible in ICU.
In critical illness, those who are on tube feed, that is what we are, specifically talking. We are not talking on patients who are on oral diet, specific to critical illness who are hemodynamically stable or unstable, who are on tube feed. This is possible, but, in general, people do not think of all those ratios when they prescribe.
Generally, the protein requirement always goes high. Around 1.2 to 1.5, and the calories may be like 75 gram proteins and 1500 calories. That also can be some of the thing, but it works well. That's what I'm trying to.
Okay. Thank you, ma'am. So going ahead, when we talk about energy requirements, so this is for Ms. Varsha. So basically, if it is like any ICU patient, how do you, in absence of an actual weight, how do you account for the actual energy and protein requirements? And how do we account for edema and swelling in that case?
This is a practical challenge where, we all struggle. How do you find the exact weight of the patient? Now we will, as we get into discussion, we'll understand that every setup is different. Some setups have the bed weighing, but also the challenge with bed weighing is that there are lots of tubes and other attachments to the patient, so you cannot rule out. The second could be any patient who is admitted or having repetitive admissions will have his admission note, OP file, where you will get the history, the file, even the simple nutrition risk screening is done. So you have an idea of that. You can be a little vague by a few percent, say 2 to 5%, you may be wrong, but at least you will come to know the body frame. So from the body frame, we can calculate. And what in our practice we do is the predictive equations, what we follow. So if we know the predictable equations, we use the rules. And then you were talking about whether there is, and of course, in kidney patients, where there is a fluid overload, pulmonary patient has fluid overload, we are talking about the dry weight. Then if there is ascites, edema, we consider whether it is mild, moderate, or severe. Accordingly, we will deduct the percentage or kilos of weight and then come to a predictive way of calculating the body weight. And then, of course, as we were getting into discussion of energy and protein, we'll calculate the protein requirements and energy requirements. We'll start at the basic of meeting up the requirements much later, but feed tolerance is important. So we'll go by 25, but if it is an overweight patient, we will go into hypocaloric planning, but meeting up the proteins as much as from 1.3, and we will slowly step up as it progresses. I'm sure others can pitch in because this is a good point for discussion.
Can I add a point to you? You did mention that, you deduct certain percentage of weight. To make it very simple, if you feel the patient has edema, 5% of the current weight, if you deduct, it is a rough dry weight. And if somebody has ascites, mild, moderate, and severe, it is 5%, 10%, 15%. As per EASL guidelines, this is how you have to do. You'll have to deduct that percentage from your current weight if you have the current weight. That itself becomes a challenge in critically ill.
True.
Yes, it is the biggest challenge because the majority of the hospitals, 95 to 99%, will not have a bed weighing scale in a functional status. It is practically not possible because all the beds does not have a bed weighing scale. It will be one bed. So you'll have to shift the patient weigh and then move the patient. Practically, it is just cumbersome. So practical aspect is that you just measure his height. Many a times, some of the patients, attenders may not be able to tell us exact weight or approximate, weight what the patient is. So what we normally do is we look at the height. We measure the height and do an ideal weight calculation. And as Anagha said, if in case he's obese, it is always better to fit into an adjusted body weight. That will really help us to get to a better approximation. This is anyway approximation, and it does not come as close to indirect calorimetry. And I want to put it in, a record here, saying that most of the patients will fit in right if they have, if they're not obese. If somebody is obese, obviously whatever calculation we make is totally wrong compared to what is measured in indirect calorimetry. I might prescribe 1,500 for a patient who is around 120 kg. You do all the calculations, 11 to 15 cals per kg body weight or less than 20 per kg body weight. Finally, you do an indirect calorimetry and measure its calories. It works up to 2,400 calories per day. We were like taken aback. That is reality. Okay. And one more set of patients whom you have to be very cautious is severely malnourished patients. We might, see them very slowly. We step up and gradually progress. But their requirement drastically changes once they are stabilized. Early phase, it can be go slow. As they progress, once everything stabilizes, their feeding pattern gets better, they are, tolerating feeds well. As you progress to the second week, third week and all, their calorie requirement really shoots very high with, indirect calorimetry measurements. As we calculate it, it is little different. So we are in the process of making some data out of it. By and large, maybe around 80% of the others, we were by and large in, proper pace, whatever baseline calculations, what we did and how we progressed worked really well.
Thank you, ma'am. So moving on the point of feeding tolerance, my next question is for Dr. Stella. So what are the conditions where you feel a semi-elemental formula will be beneficial, and like how do you improve the tolerance of these patients?
Okay, thank you so much. Semi-elemental diets are normally very essential in a hospital setting. Every nutritionist should have them in mind when you're taking care of patients, because they come in with different elements, especially those that affect the gut. And the gut is key and paramount in seeing complete absorption. So patients that could have intolerances, IBM, could have patients with pancreatitis, could have patients that are post-surgeries with laparotomies done. So all these patients could be key in semi-elemental diets. But as you test for their absorptions, this is when you can determine whether they are suitable for a semi-elemental diet. Other cases that are important is where patients can't tolerate feeds. They have frequent bowel movement. This also shows you that maybe they can't tolerate the food that is being given. Is it a high fiber diet? Is it full of complex carbohydrates? Or it is a post-surgical issue? Is this patient allergic to some food maybe that you didn't know on admission? So all these are key and paramount. Remember, these patients are also put on vasopressors. They could suppress the gut. So semi-elemental diets, since they are hydrolyzed, are easy for the gut to absorb and can help the patient improve nutritionally and to have an active gut instead of you holding enteral feeding completely. So it's key to identify what your patient would need. Is it adequate in protein, a semi-elemental diet that is high in protein? Is it high in energy? Is it moderate? So your patient will guide you on what kind of semi-elemental diet they would use. And also age matters. As patients grow older, yes, they might find a challenge in holding food. Is it an infant? Is it a neonate? We could find that maybe they have lactose intolerance. All these need to be identified for you to start elemental diet. And then checking the patient absorption is very important. And do they complete their absorption? Do they have a good gastric emptying whereby the bowels are well formed and just on time? They are not frequent. That one also should guide you a lot. If they delay bowel emptying, yes, they might absorb, but they are not emptying. It also is a guide to show you that this patient could need a semi-elemental diet. Monitoring is key and paramount. But as you're on a semi-elemental diet, yes, you start bringing on foods that are either freshly made, but with considerations of what your patient can tolerate. If there are intolerances in the diet, you have to put them out so that you can introduce a normal healthy diet and reduce some semi-elemental diet. Yes.
Thank you, ma'am. So one additional question on this is like, what in case of diarrhea? Do you prefer a semi-elemental diet in case of a diarrhea in patient?
Yes, it would come in very handy because we don't know what is causing the diarrhea. Until we identify what is causing the diarrhea, it would be a very good starting point as you start eliminating if it is in the types of food, is in the process in which the food is made, is it a food poisoning, is this patient allergic, until you get to know what causes the diarrhea. Is it the food, is it clinical? Then a semi-elemental diet can be introduced. Yes. But it is very essential. Can keep your patient well nourished and they work well with the gut. They normally support the gut well and will stimulate normal absorption. Yeah, because they are composed of, we have fats, we have moderate protein, we have energy, carbohydrates, they have variety. So it's important for the nutritionist to identify which particular one the patient will do well with.
Thank you, ma'am. So now moving from semi-elemental diet, my next question is for Dr. Anagha. I think Dr. Daphne touched slightly on the immunonutrition formulas in ICU, basically in surgical ICU patients. So what is your take on immunonutrients in critically ill patients?
Yeah, so immunonutrients formula are the ones which are enriched with a glutamine, arginine, and omega-3 fatty acids and some other nucleotides. So glutamine and arginine are typically the fuel for the colonocytes as well, I mean the enterocytes and the immunocytes mainly. And they are the conditionally essential amino acids. So generally but again, as per the guidelines, just as a reference point, not every critically ill patient needs immunonutrients. So glutamine is particularly seen to be extremely beneficial in patients with trauma, burns, and in cancer treatment. So in those cases, yes, immunonutrient-based formulas are good. Glutamine use, particularly in liver impairment, is not really recommended because excessive glutamine use can give rise to ammonia, which can be difficult for liver to handle. So therefore, it should not be used in these cases. Arginine can get synthesized into nitric oxide, which is a vasodilator, and therefore it is typically contraindicated in patients with severe sepsis. And in these patients, cannot be used. Omega-3 fatty acid supplementations, both enteral and parenteral, are recommended, and we have used successfully in patients with respiratory ailments, typically in acute lung injury and acute respiratory distress syndrome, and it works really well. So yes, immunonutrient formula in a medical intensive care unit, it does not have much really relevance, but in surgical ICUs, post GI surgeries or post-cancer surgeries, or in trauma burns section, they really do well and can be used. So you can use a formula which contains these immunonutrients, or you can use them separately as an addition to those formulas.
Okay, thank you, ma'am. So there's one question on serum sodium levels. I would like any of the panelists to take it up. So it is most of the patients in ICU have observed high serum levels. So what is the solution instead of a low salt diet, especially in tube feeding?
Okay.
Serum,
can I start?
serum sodium.
Yeah.
So,
so basically,
we have seen,
yes, ma'am. Yes, ma'am.
So we have seen hypernatremia in many of the neurological conditions, particularly post-neurosurgeries, major things we've seen hypernatremia. Sometimes even in severe, in MISU patients also, when there is dyselectronemia, we do have seen hypernatremia. And what works really well in that is giving free water. So the physician will calculate the free water, and it could be given as 50 cc RD or 100 cc RD. And that helps to really control hypernatremia really well. And when there is hyponatremia, then generally there will be a 3% concentrated NaCl added to the IV by the physician generally. Or then you again coordinate with them and you decide the amount of additional salt you can add in the fields, and that works really well. That's what we've been doing in management of hypo and hyponatremia.
Agree.
Yes, if I can say something on that, it's ideal. Can I go on? Yeah, it's ideal to maintain a low sodium diet, unless to the contrary, because remember we are dealing, though electrolyte imbalance, electrolytes done almost on a daily can guide a nutritionist on the direction to take, because we would want to improve the patient as much as possible. We could have could have a patient maybe who has renal issues, they are hypertensive. Many of these conditions, a low sodium diet is greatly recommended. And then we could monitor as per the levels and manage, but a low sodium diet is greatly recommended. But we can correct as the patient is being monitored.
Sometimes, I would again like to add to that, sometimes, there could be dilutional hyponatremia, especially in patients with liver disease or in patients with renal disease or even cardiac disease, there is fluid overload. There is a possibility that because of the fluid overload, there can be a dilutional hyponatremia, and that you need not treat at all. That will be taken care of by the diuretics as well. So we have to really rule out the cause of hyponatremia over here and the cause of hyponatremia over here. So if it's hyponatremia due to excessive fluid overload, then the diuretics will take care of it. You don't need to put extra salt. It will worsen the scenario. That one thing you need to also take care of and remember.
No, dilutional hyponatremia, I would like to add a word. Normally they do restrict salt, do not add salt, and you'll have to have a stringent volume restriction. That is mandated for dilutional hyponatremia. for it to be normalized.
Yeah, that's what I said.
Because
So
they
you don't need to add
Yeah.
extra salt over there at all.
Yeah.
You need to
No,
restrict-
many places
Asha.
people do advise extra salt. That's why I emphasize.
No. That's no, not at all. In dilution, don't add extra salt at all. Let the diuretic and the fluid take care of it. Restriction.
Strict fluid restriction is a mandate.
Yes.
Thank you, ma'am. So for the next question, it's open for all the panelists. So in critically ill patients, they may face reduced ischemia, GI hyperfusion, or mesenteric ischemia. And enteral nutrition may trigger intestinal ischemia in patients who are not hemodynamically stable. So we also read about starting the early enteral nutrition early so that the gut, when functional, should be used. So in this all conditions, how do we time the right time for enteral nutrition?
So the right time when you talk about, starting EN, as Anagha was, talking about early feeding, it is as early as 24 to 48 hours. I would say in our experience, it's less than 6 hours, as early as possible. Once the patient is hemodynamically stable or he is, fluid resuscitated, his, BP is normal. Once it is stabilized, they can start. So it can be less than 6 hours. I can tell you more than 90% of our, critically ill patients in one of the study that we did, we could feed them as early as less than 6 hours. So that is feasible. The other part of it, what you mentioned about, gut ischemia, when will that happen? When somebody is hemodynamically unstable. What is hemodynamic instability? The Anagha did speak a detailed note on hemodynamic instability. And how do we find out when to start? That is a question. It is very, very simple. When the patient goes on a downward or declining, vasopressors or inotropes, less than 2 numbers and declining dose, then that's the time you can start feeding the patient. How much can we feed? As minimal as trickles. 15, 20 mils. It is not to achieve targets. It is to keep the gut intact. So if you feed them in an inappropriate time, wherein they are in high dose of inotropes, 3 numbers of inotropes, increasing dosage, then that will land up with gut ischemia, because EN or feeding the patient through the gut becomes a problem, and that will lead to ischemia. Okay, hope I made it clear.
I remember when I used to also work with Benjamin Man in the ICU, that's when we used to say feeding, as soon as the patient is hemodynamically stable, feed at 0 hour is what we used to say. So as to don't even wait, start feeding the patient as soon as the patient is is hemodynamically stable. You can't really measure the gut ischemia part, or whether there is gut ischemia or not. But as ma'am rightly said, that as the inotropic support gets lesser and the patient is maintaining blood pressure, there's no hypoxia, respiratory rate, all those parameters are stable, you can initiate feeding. And yet, as trickle feed, tropic feeds, gradually you can progress and meet your requirements. That's the hemodynamically stable thing is very important. That's the key.
To add something to that, I agree with my colleagues so much. Stability matters. And then the amount we feed, the key is to kickstart the EN as much as possible. So we can start with smaller volumes increasing as the patient is stabilizing that feed.
And in such patients, maybe continuous feed will work much better, because in critical care, we are accustomed to continuous feed. That will work well with your gut.
Yes, I agree. Perfectly right time to put forth, Varsha, because bolus feeding can, cause, increase gastric residual volume, and that could become a problem to feeding. So continuous is the best when we talk about such critically ill patients.
Yeah, especially in the compromised gut or the gut ischemia.
Exactly.
Yes, ma'am. Sorry, yeah. So I think there are many questions coming in. So we'll just take one last question and then we'll have some closing remarks. So one last question is like when we were talking about the weight of the patient for calculating the calorie energy, there's one question when there's both not height and weight possible, then how do you calculate, or what is the requirement? How do you do the energy requirements?
That's unlikely, right? I mean, height may be possible.
Okay.
Hey,
Should
it
be
is just it's just a measuring tape which is required.
Yeah.
You'll have to just stretch and measure. That's practically possible, and we do it in our ICUs day in, day out.
Okay.
So,
Right.
you know,
Can be measured.
just, it is possible.
Okay, one last question, ma'am. So if patient develops severe diarrhea on starting drip formula, feeding on Jejastromy feed, provided with correct drip and rate and dilution, what will be the causes in that case?
You'll have to check on the medication the patient is on, and check on the type of feed that you're giving. Check on the hygiene part, how it is prepared, and the drip rate, whether it is high or whether the pump is functional. Sometimes what happens, suddenly one gush, it can go.
Right.
And many a times nurses may not tell us what went wrong. They will just put it under the carpet. That's common in all our settings. So you have to be really cautious. Look at all the drugs, which can be factors which can induce. And one more thing is the infection. So you know, checking on C. difficile would be one first thing that we do before changing the formula. So we
Please be noted.
In addition, maybe, sorry. Sorry, in
So
addition,
if
yes,
in
Dr.
case, if in case, you are sending the test C. difficile, what I normally practically do is start with a soluble fiber. And if C. difficile is positive, it relates to your, antibiotics. You don't have to change automatically. Doctors will make the corrections. Things will settle within few days. If in case it is negative, then it is on your part to change the polymeric feed to peptide formula along with a soluble fiber. That works better.
Also, I think one more point we need to check is what's the frequency of stools? Because when you start patient after a long time on a liquid formula, patient may report as liquid stools or that kind of a thing. But whether it's persisting for a long time, how many stools, loose stools, that history is also very important. Sometimes when you check with the patient, they'll say, so many episodes, but then when you actually cross-check, it's not that much. So the frequency of stool is important. And as ma'am said, sometimes, the drip rate is changed and the patient will tell you, this got over faster. And then you cross-check and then the sisters will kind of say, it could have fast over. And that also can lead to, that. So yes, these factors need to be checked. And sometimes diarrhea definition is so different for everyone that it may not actually be diarrhea. You can be little patient and check whether it's continuing the next day or whether it's really that bad or that frequent. And then you can take it. But yes, if it persists, then you can change from polymeric to a peptide and or check the drip rate and then decide.
So monitoring is also important while we plan, prescribe, elemental, what kind of diarrhea it is or not. So monitoring, we have to have a second round in such critical patients or where they are reporting diarrhea, because we need to check back what is going wrong, whether the medication needs to be changed, nurses are giving it properly, or they're just flushing it, whether the fiber component is taken care or not. All this needs to be looked at.
And one more thing, if in case the nurse is preparing the feed and, she is feeding, in many settings, we have, earmarked place where, it is prepared under laminar air hood and sent. So we take control of it. In many settings, there are nurses who will prepare. How it is prepared, with what water it is prepared.
Yes.
Every component has to be looked at, practical aspects, not only the drugs and other things. Even water, what water is used. That also can cause. Yes. And the definition of diarrhea, as you said, it is very, very vague. People take it very, very differently. Very simple. It is more than 2 or 3 episodes of loose stools. You should talk about the consistency of the stool also. If it is totally loose, then you act. And that too, looking at all the parameters, you don't change the product immediately. You give it for testing, check all, every aspect of it, then you make the change, not immediately.
Thank you so much, ma'am.
They could
Yes,
run a
ma'am.
stool analysis as well. A stool analysis could also be accompanied with all that has been mentioned. It could also guide if it is persistent diarrhea.
Thank you so much, ma'am. So it was an excellent session from each of your panelists contributing your own practical experiences, what happens in the ICU. Any closing remarks anyone would like to give to the dietitians today who are attending? Like what are the aspects they need to look at when they are treating an ICU patient? I know it's quite dynamic. A lot of things are involved, but any closing statement you would like to give anyone?
I think I gave when I was finishing my presentation, and what I still think very strongly is that yes, we need to have the guidelines should be always taken as a reference point, but we also need to have a very, very good reality check about which setting we are working in, whether we are in whether we are in a, see, in different settings, there will be availability of different resources, availability of different kind of gadgets, some may have some may not have it. But even then, we need to be really, really try to work upon the best for our patients. And yes, every setup, again, I would say may not have, the continuous drip. But if we have bolus, then what? How we can make it work in the best way? Because we are a developing country, we live in metropolitan cities and we may have all the facilities, but every place, any country, basically anywhere, may not have the ideal setup. So we need to really try to get to the best of how can we get guidelines is one thing, but how we can make any protocol for our patients that we can make the best of it and give the best protocols to our patients and get the best outcome. That's very important. So yes, we need to look for the ideal things available also, but do not leave behind what are your actual limitations and still try to be best. That's what we should do. The best of both, I would say.
So to sum up, I can say, as she said, there can be variations in settings, your equipment, your formulas, everything. But the simple thing is work as a team. Multidisciplinary team approach is mandatory. There is a doctor available in your team. You are the dietitian. Coordinate with your nurse. That sync has to be there. Everything else will fall in place automatically. You will start working together for the betterment of the patient. So, the difference of opinions can be thrashed very easily if you become a team player. That's very, very important. And as dietitians, we should aim to do that. Wherever there can be dialogue, sometimes doctor can be wrong. You are right. Make a dialogue, have a dialogue, open it up, speak, correct it, thrash it. That's it. It's over. The next day is a new day. You start working. So the bondage becomes stronger. You work really well, and your patient will get benefited out of our teamwork. That's the message I want to pass on.
And I also recommend that dietitians must take, or even students who are interns, to take round with the MICU team. So when they take daily rounds, be part of those rounds, and you learn a lot on those medical rounds about different patients, the different investigations, their significance. And there have been many times when, as I say, guidelines are your references. So whenever there is any kind of two opinions, you can always show the references. So we keep updating yourself and keep updating about the recent advancements, which can be then also shown to your medical team as a reference for any new thing or changes that you're making. And that's how the communication improves. I agree with you.
Adding on to communication, I think documentation is also very important, because when we are showing a step up or progression, I think then only we will figure out whether we are meeting up the requirements, 50%, 70%, how much kilogram. So later when we discuss this as case learning or, evidence-based proof, these things are really going to help us.
Thank you, everyone. I also want to affirm that a multidisciplinary approach is key and paramount in managing critical care patients and other patients as well. Because remember, as we are doing fluid restriction, it affects the nutritionist most, and it is so painful, and it's when you want your patient to feed, maybe they're on dialysis. So it is key and paramount to have a multidisciplinary approach to emphasizing the ward rounds. They are working so well for me, and then working with the team and following up in your 24 hours to see how much was given. Did you reach the target? If not, what didn't you get? Why did you get that far? So this one helps you a lot, and you see your patients out of ICU, not malnourished. Yes.
Thank you so much for giving that snippets, like what should be remembered, that is from all the panelists today, and for excellent contributions for in practical experiences. I thank all the participants joining today. Some questions which were unanswered, we will try to share it with you on email. Thank you for joining us today. Our next session will be on next Wednesday, which is on hypercatabolic conditions. So please join us on next Wednesday. Thank you all the panelists, and goodbye. Good night.
Thank you.
Thank you, everyone. I
everyone.
had a really
Bye-bye.
nice
Bye-bye.
time
Thank
interacting
you.
with you. Thank you so much.
Thank you.
Bye-bye.